Purpose of the talk are to essentially review evidence in patients with need for pacing. What choice do you want to use when you are using a device for pacing? What is the role of symptom rhythm correlation? Because the patient has an abnormality in conduction, does the patient need a pacemaker? And some challenging questions that all of us face on a day-to-day basis. So let's start with the case one, where you have a 15-year-old student who is very interested in athletics and now presents to you for an opinion in a form of a pre-athletic checkup. Physical examination is for a soft S1, the echo is also not. This is the ECG of that particular patient. Now, if you take a look at the ECG, you can actually appreciate the fact that the P waves that are seen in the ECG have a normal axis. The QRS of that would be normal. Every P wave is followed by a QRS. But what is abnormal is that the PR interval that seems to be prolonged. So that's what possibly is present in this particular athlete. And it's up to us to decide whether there is significant pathology here to decide any abnormalities. Remember, this patient does not have any symptoms and has come as a part of a pre-athletic checkup. So what you can see is definitely AV block, first degree. As I mentioned, the P. So in a patient, PR interval is prolonged and the patient is relatively young, there is the possibility that it's a structural abnormality in the form of a fixed first degree AV block. The other possibility is that the patient could have hypervagotonia or vagotonia, as it is more commonly known, wherein overactivity of the vagus results in increased inhibition of the AV node, resulting in enlargement of the PR interval. So in such patients, whenever you get them, it is important to see the PR interval is fixed or it is variable. By variable, the heart rate increases, the PR interval should shorten if that happens or not. So the next step you do in this patient is a TMT. Why a TMT? Is because when you do a TMT, there is sympathetic overactivity. The vagal tone, if it is high, which is one of the causes, will be withdrawn. The PR interval will shorten, and you will know that this is more a case of hypervagotonia rather than a case of fixed PR interval prolongation. Now, assuming that during exercise, the PR interval prolongation remains fixed, but because the patient has no symptoms, it is not an indication to put a pacemaker in place. So going on from there, let's go to case number 2, where we talk about a 45-year-old who complains of skipped beats presenting for opinion. As expected, the physical examination is normal, the echo remains normal. This is the ECG. Look at the ECG just like in the previous case. You can see the sinus P wave, you can see a QRS. What is striking about this ECG on first glance is that there is grouped beating. So let's take a look as to how you want to evaluate this ECG. Now looking at the P wave, it is positive in lead 1, it is positive in lead AVF, and if you look at lead V2, it is positive there too, suggesting that this is a sinus node exit of the P wave. Now every P wave, unlike the last case, is not followed by a QRS. The easiest way to take a look at it is to look at the rhythm strip at the bottom of your screen, where you can see that this P wave is followed by this QRS, this by this by this, by this, and then suddenly it drops. So not every P wave is conducted to the ventricle. So there is some amount of atrioventricular block. It is a type 2 block, mainly because not every P wave is conducted to the ventricle, and there is less than one P wave, consecutive P wave, that is dropped. Now, taking a look at it slightly more deeply, you can notice that the PR interval keeps on prolonging until the blocked beat where the PR interval is completely lost. Similarly, the PR interval after the blocked beat is the shortest PR interval of this particular sequence. This features, as I described right now, is suggestive of a Mobitz type 1 Wenkebach sequence. This again can be one of the reasons for feeling palpitations, but does not remain a cause for requirement of pacing. This can be induced by hypervagotonia again. One of the key features that helps us discuss this is the presence of a narrow QRS complex as opposed to a wide QRS complex. So the block is likely to be within the AV node and therefore likely to also have contribution from the vagal tone. What is definitely more worrisome in this ECG is the presence of the ST elevation in the inferior leads, suggesting that there is an acute inferior wall myocardial infarction going on. And as we all know, the pathology of it, there becomes a hypervagotonal state leading to this kind of block. So in this patient, definitely no need for pacing, but you want to urgent revascularization depending on what the presentation of the patient is. It is very common for inferior wall myocardial infarctions to have this kind of abnormal AV block. It does not require a pacemaker unless this rhythm is persistent beyond 21 days. So the question for this particular ECG would have been, is a pacemaker needed? Answer would be a definite no. Going on from there, we go to a 58-year-old female who's a known case of diabetes and hypertension. She is obese, she's also having a history of an anterior wall myocardial infarction 6 months ago. She was not revascularized. She again presents with complaints of skipped beat. On presentation, the physical examination was relatively normal. Echo was suggestive of an ejection fraction of 45% with a regional wall motion abnormality in territory of the LAD. A physical examination normal, I mean that there doesn't seem to be any cardiac pathology at this point other than some skipped beats. When you look at the ECG, again, the striking feature on this ECG is that you see group repeating. Just like the previous case, you see a P wave which is positive in 1, positive in AVF, and positive in V2, suggestive of a sinus node exit of the P wave. The QRS is again narrow, and if you look at the P following and the QRS following the P wave, you can actually see that just like in the previous case, the QRS drops. So not every P wave is followed by a QRS. Once we reach the same stage, we are again into the question that, okay, we are dealing with a second degree AV block. Why I call second degree AV block is because not more than one P wave is blocked conducting to the ventricle at any point in time. So when that is the situation, we again in the previous case looked at the PR interval. In contrast to the previous case, here the PR interval is fixed. There is no significant change in the PR interval before the P wave that is dropped, suggesting that perhaps a more sinister form of AV block, namely a type 2 AV block, Mobitz type 2. A Mobitz type 2 AV block is worrisome because it represents an infra-AV nodal block. In this case, it's a narrow complex QRS, but usually could present with wider complex QRSs and is suggestive of a condition which can precipitate into a complete heart attack. Remember, this patient had an old anterior wall MI which was not revascularized. This is commonly present in patients with anterior wall infarctions, especially in the acute stage. In delayed stages, when has not happened, this could also present at that time. So the question for this particular ECG would have been, was a pacemaker needed for this patient? Answer is a resounding yes. See the difference in the two ECGs that I showed. One had a PR interval that was changing with a fixed P wave morphology arising from the sinus node. Whereas in this case, although the P wave was arising from the sinus node, the PR interval remained fixed before the dropping of the P wave conducting to the ventricle, suggesting of a Type 2 mobility, second degree AV block. We come to case 4, where a 72-year-old male, known case of hypertension, presents with complaints of fatigue, and physical examination shows characteristic Canon A waves. A screening echo shows a normal ejection fraction with left ventricular hypertrophy. Now, let's take a look at this ECG. At the outset, what you can see is there is more than P wave that does not get conducted to the ventricle. On closer scrutiny, again, we look at the P waves. It's positive in 1, positive in AVF, and positive in E2, suggestive of a sinus nodal exit of the P wave. And the QRS is relatively broad, a right bundaloid morphology, and more than one P wave is not conducted to the ventricle, suggesting that this is a more sinister form of AV block, namely high grade AV block. This AV block definitely needs pacing, and before you condemn patients like this to pacing, make sure that the P wave remains at a sinus nodal exit. That is what I kept telling, where it is positive in lead 1, positive in AVF, and lead 2. Sometimes you get non-sinus rhythm, non-sinus P waves which block to the ventricle. There it's more an atrial arrhythmia that is blocked to the ventricle rather than a high-grade AV block. In those patients, termination of the arrhythmia may resume normal AV conduction. In these patients where the sinus node gives out the P wave, the pacemaker remains our only solution. So this is advanced or high-grade AV block, where the ventricular activation is maintained either by a junctional with a narrow complex QRS or a ventricular focus of escape which has a wide complex QRS. Is a pacemaker needed? The answer is yes. Here we have case number 5, an 84-year-old female, known case of atrial fibrillation with senile aortic stenosis. She underwent a TAVR for severe symptomatic aortic stenosis, presenting with new onset shortness of breath 1 day after the procedure. Physical examination shows regular pulses, bradycardia, and the apex pulse deficit remains less than 10. That is strange when you know that she's a known case of atrial fibrillation, probably permanent. The screening echo shows a normal ejection fraction, normal LV, and a slow heart rate. When we take a look at the ECG, you can actually see that there is no fixed baseline. You cannot comment on the P wave in this patient at all. This, as I contrast from the previous case, is a case of an atrial arrhythmia. Now, you may argue, why are we worried about an atrial arrhythmia conducting to the ventricle when I just mentioned there is a problem? It can actually be treated by cardioverting this patient or reverting the atrial arrhythmia. But the sine qua non of a patient in atrial fibrillation, which is what this is, where you can't make out the P waves properly, is that there has to be irregularity in the ventricular response. So when you see an arrhythmia like an atrial fibrillation where P waves are not consistent or do not look the same, and there is no isoelectric baseline, but the conduction to the ventricle remains consistent, stone cold, consistent, that is suggestive of an AV nodal block in the presence of atrial fibrillation. One may even say that the P waves are seen. This is a sawtooth pattern. Why is it not an atrial flutter? I would draw your attention to lead V1, where if you see that the P waves are not, or the flutter waves are not looking the same. If it is a flutter, the flutter waves need to look at every point in time. Absence of that is suggestive of a possible coarse atrial fibrillation. And in the history of this patient having received a aortic valve, the possibility that this has led to an AV block, which is indicated in this ECG by the regularization of the ventricular response to the atrial arrhythmia. So this is atrial fibrillation with a slow ventricular rate, suggestive of a AV nodal block in the presence of atrial fibrillation. Pacemaker needed in this case? Most certainly, pacemaker is needed in this case. Then we have an 80-year-old male who with senile aortic stenosis who has undergone a TAVR, who presents with a new onset shortness of breath 1 day post procedure. The physical examination again shows regular pulses. The screening echo shows an ejection fraction of 60% with a normal LV and a slow heart rate. Now let's take a look at this ECG. This ECG is a little bit funny because in this ECG, again, you can see a widish QRS complex. You can see fragmentation in lead V5, V6. And I have to kind of look very, very hard to start seeing the P waves. If you want to see the V1 P wave, it seems positive. I can't see any P waves very well in this particular ECG, although perhaps there are low voltage P waves that you can see, which makes you worried for a coexisting underlying substrate that this P wave may not be very well seen. Now, taking a look at this and saying, oh, the patient has a junctional rhythm may not be the source. You look at the P wave here, look at the conduction to the ventricle, it is prolonged. This P wave conduction to the ventricle is prolonged. AVF, again, the P wave is positive, one perhaps not very well seen. But still, even if one does not show a positive P wave, isoelectric P wave, axis remains consistent. And let's take a look at V2, the P wave is positive. So there is a sinus node exit to the P wave. The coupled beating that you can see here is probably because of small APCs where the P wave in that particular lead is not very prominent. If you look at lead V1, let me take across lead V1 where this P wave is conducted to the ventricle with a PR interval that is prolonged. This P wave conducted to the ventricle with a prolonged PR. This P wave conducted to the ventricle with a prolonged PR. But look at this T wave compared to this T wave. You can see that there is a probable APC here that is also conducted with a prolonged PR. But the irregularity is because of these APCs rather than because of any other pathology. So again, this is first degree AV block with APCs. Again, in a patient with a TAVR, but does not probably require a pacemaker at this point of time. Because the PR interval is prolonged, careful observation to see worsening is critical. The slight irregularity that you see should not provoke you to get a pacemaker in these patients. Going on from there to case 7, in a 62-year-old female, hypertensive patient on amlodipine and beta blocker, presenting with new onset shortness of breath since 1 day. Physical examination shows a slow regular rhythm, Canon A waves on JVP, screening echo with an ejection fraction of 60% with normal LV and a slow heart rate. Now, taking a look at this ECG, at the outset, immediately you can see that probably not every P wave is followed by a QRS. There is a slightish, widish QRS that you can see. Axis of the P wave 1, AVF is positive. Again, V2 is positive. Sinus nodal exit of the P wave. And not every P wave is followed by the QRS, suggestive that it is an AV block because there are not more than one P wave that is blocked to the ventricle. It is a second degree AV. So that much is consistent. If you want to take a look at it further, is the AV block in the infrahisian conduction system or is it in the AV node? Look at the PR interval of the conducted beat. The PR interval of the conducted beat is normal, suggesting that it is a AV nodal block that has resulted in this problem. Now, why it is important is because this is an elderly gentleman and is on beta blockers. So what do we do for these patients? We are worried that this patient may develop an AV block in times to come. Whether to stop the beta blocker or to give a pacemaker directly remains a question. It remains a matter of worry because two things have to be considered. One, the necessity of the beta blocker as an urgent medication, and the fact that the patient is on beta blockers and getting an AV block, which is an unusual phenomenon, suggesting that there is intrinsic AV nodal disease present. So if the beta blockers are essential in such a case, then you give the patient a pacemaker. If the beta blockers are not essential, You stop the beta blockers, see for improvement. If the patient doesn't improve, give the patient a pacemaker. But if the patient improves, make sure that you tell the patient that the reserve of the AV node is poor and the patient may require a pacemaker in times to come. So pacemaker for this patient was needed because the beta blocker was important, and so patient should get a pacer. We come to case 8, and please stop me if we are going over time. Happy to stop at any point. We have a 68-year-old male who's a known case of SVT on a beta blocker presenting with fatigue, again showing a slow regular rhythm with a normal ejection fraction and a slow heart rate. Taking a look at this ECG, we can see that it's a narrow complex QRS. Every QRS is preceded by a P wave. Looking below down here, you don't see a P wave that is blocked. The P wave is positive in 1, positive in ABF, and V2, the P wave is positive. The PR interval is relatively fixed, suggesting again that this is a sinus node exit of the P wave, normal QRS complexes, no block 1:1 from the no block between the atrium and the ventricle at any point, but the heart rate is slow because the P waves themselves are being produced at a very slow rate. Remember, this is a patient for an SVT where the beta blockers were given. It may be prudent to just stop the beta blocker and see how the patient responds. This is sinus bradycardia in response to the beta blocker. How do you decide whether this patient has intrinsic sinus node disease or a beta blocker induced sinus node disease or sinus node dysfunction? You basically do a TMT to help in this decision making. You stop the beta blocker for 5 half-lives, and after the beta blocker is stopped for 5 half-lives, you make them exercise on a treadmill, see what is the maximum response of the patient in terms of his heart rate at maximal exercise, calculate what is called the chronotropic index, and that will help us in making this decision. Case number 9 is a 45-year-old female, known case of ASD, status post cardiac surgery for correction, came for review of the ECG. Physical examination shows a slow regular rhythm. Screening echo, as usual with our cases, 60% with a normal LV function. So take a look at this ECG. Again, when you take a look at this ECG, what is very striking is that there is a long pause here, after which when you look at the other ECGs, other heartbeats, you can see that every P wave is followed by a QRS. There is no obvious AV block here. Looking at the P wave, lead 1 is positive, lead AVF is positive, lead V2 is positive, suggestive of a sinus nodal exit with a normal QRS width. So this pause that you see here is essentially the pause secondary to lack of production of the P wave. This is again a sinus pause. Now, when you get a sinus pause, what we can do is correlate the interval of the pause. If the interval of the pause is a multiple of the underlying P to P interval, you can always say it is a sinoatrial exit block where the beat that is produced in the sinus node is not able to exit to the ventricle. Remember, this patient had an ASD surgery, open heart surgery. The cannula that is put for the ASD surgery is put at the location of the SVC-RA junction. Perhaps some amount of scar there may cause this problem in such patients. Again, if the patient is asymptomatic and is able to tolerate the sinoatrial exit block well, including with exercise on a TMT, nothing needs to be done. But in this patient, you had the patient who has just come in for a review of ECG, probably nothing else needs to be done. Again, does a pacemaker needed? The answer is probably no. You, however, want to see if there are very long pauses in the help the patient prognosticate, and so a Holter may be needed to aid with management. Coming to our final case, we have a 45-year-old female, known case of Jogren, with repeated episodes of Synco, presenting for review of the Holter report. The screening echo is normal, 60% with a normal LV function and a slow heart rate. And when we take a look at the Holter, remember this is a Holter, this is not a ECG that we have. You see that strikingly there are pauses in between. You cannot see a blocked P wave, so these are sinus pauses. If we look at the P waves in the beats before, you can see that the P wave is positive in lead 1, the P wave is positive in lead 3, which is a surrogate for AVF, suggesting that probably it's a sinus exit of the P wave that is present. And looking closely at these pauses, you can see that there is no sinus P wave that you can note across. These are narrow complex escape beats without a sinus P wave, suggesting that this is an entirely huge big sinus pulse. So the question here is, does this patient need a pacemaker? Now, before we make that decision, the critical piece of information that you want to see is what time is this particular pause? Is the pause present at night or is the pause present during the day? Remember, patient has had a syncope, so there may be other mechanisms of syncope than the sinus pause, and it is not uncommon for us to see sinus pauses at the night time when the patient is sleeping, especially in patients who have obstructive sleep apnea. So whenever you see sinus pauses on a Holter, make sure that you look at the sinus pause timing to decide whether or not this patient needs a pacemaker. If it's a daytime sinus pause, this patient may need a pacemaker given that she's had an episode of syncope, and it's likely that the sinus pause in the daytime has contributed to her episodes of syncope. However, a nocturnal pause should be treated with a little bit more care, as the cause of syncope could be any other reason also. In this patient, would you definitively need a pacemaker? Perhaps not, but we need to see the time of the episode on the Holter. So, in summary, therefore, in patients with conduction tissue abnormalities, symptom rhythm correlation is critical. Sinus node dysfunction is never diagnosed at rest. It's very unusual to have a activity based sinus node competence and a sinus node dysfunction, whereas a at rest sinus node slowing with activity based sinus node increase to age related maximum is very common. The differential that has to be ruled out is hypervagotonia. Whenever the pacemaker is to be implanted for sinus node disease or dysfunction management, the pacemaker has to have a rate response. Otherwise, we are not doing anything for the patient. It preferably needs to have an atrial lead and a ventricular lead. But if only one lead has to be put, then it has to be put in the atrium. And at that time, you should evaluate the atrioventricular conduction to decide if that is safe enough to put the lead in that location. Symptomatic AV block of any type is an indication for pacing. Asymptomatic AV block, if the patient is more than Mobitz type 1, that is the PR interval is fixed and there is lack of conduction or a sudden loss of conduction of one sinus P wave to the ventricle. Even if that is asymptomatic, you will need pacing in these patients. For patients with first degree AV block and Mobitz type 1 AV block, unless there are symptoms, there is no indication for pacing. Temporary pacing is life-saving and perhaps everybody should attempt to know it, how to do it. The gray areas remain syncope in patients with bifascicular and trifascicular block, which for reasons mentioned, I have not gone into the details of. Thank you very much for your patient hearing. You can have some questions right now. This is my contact. Some queries are there. I'm happy to answer them. Otherwise also. Thank you.
Thank you, Dr. Deepak, for such an excellent presentation and in-depth presentation.